Good morning, everyone. So I'll be discussing the 12-year incidence of intraoperative expulsive suprachoroidal hemorrhage among glaucoma surgeries at a tertiary care hospital in South India. Now, my objectives are twofold: to analyze the incidence of ESCH and to highlight the steps that can be taken to prevent this complication. A rupture of the long and or short posterior ciliary artery can cause blood to pool in the suprachoroidal space. This condition is referred to as suprachoroidal hemorrhage. The abrupt extrusion of intraocular contents through a corneal or scleral defect is a characteristic of the expulsive form of suprachoroidal hemorrhage, which can present either intraoperatively or have a delayed presentation. Now, for this study, we will take a look at the intraoperative form of expulsive suprachoroidal hemorrhage, which was diagnosed based on intraoperative findings and confirmed with a post-operative B scan. Some of the risk factors for ESCH will include sudden decompression of the anterior chamber, leading to a sudden decrease in the intraocular pressure, myopic patients, aphakia, systemic conditions like hypertension, and preoperative high IOP. Now, postoperative hypotony is the most common cause of delayed ESCH. Any intraocular surgery possesses a risk of ESCH. High preoperative IOP and sudden decompression of AC are more common in glaucoma surgeries, which would explain the higher incidence of ESCH when compared to other surgeries. Now, this is a retrospective observational study that includes all glaucoma surgeries within a study period of 12 years. Only intraoperative ESCH was included and delayed presentation of ESCH was excluded. So, a total of 27,461 cases were analyzed. There were 8 cases of intraoperative ESCH, which gives an incidence of 0.03%. Now, 1 case in 2010, 4 cases in 2013, and 1 case in 2014 occurred during combined trabeculectomy and cataract surgery. Now, 2 cases in 2014 occurred during trabeculectomy. So, one point to note here is that because of the occurrence of ESCH from 2010 and to 2014, from 2015 there was a change in the protocol followed in the institution backed by risk stratification, which I will discuss later. Now, all of the 6 combined procedures were trabeculectomy with manual small incision cataract surgery, and 5 of those cases had rent of the posterior capsule. The post-operative vision of these patients was poor. Nucleus delivery was the most common step at which ESCH was noted. The most common intraoperative finding that alerted the surgeon to a possible complication was sudden hardening of the eyeball, in addition to other signs like sudden severe positive pressure, constant prolapse of the iris through the tunnel, or opening and the inability to place sutures while closing. Sclerostomy was not indicated in all of the patients. So, in all 8 cases of the ESCH were confirmed post-operatively with a B scan. Apart from hemorrhage in the suprachoroidal space, 2 cases had retinal detachment and 2 cases had vitreous hemorrhage. Now, hypotony and IOP fluctuations are thought to be the primary pathogenetic mechanism. Abrupt hypotony results in the development of high transarterial pressure gradient, which causes the short or long posterior ciliary artery to burst and bleed in the suprachoroidal space. Now, complication can occur during any intraocular surgery, no matter the proficiency of the surgeon. It is very important that we are able to identify signs of ESCH intraoperatively, which include a sudden increase in positive pressure, which can lead to shallowing of the anterior chamber, inkling and bulging of the posterior capsule, loss of red reflex, hardening of the eyeball due to an increase in IOP, and sudden extrusion of the intraocular contents. Now, the higher risk of ESCH in trabeculectomy, also seen in our study, may have prompted a change in the way glaucoma surgeries are approached. Now, countries like Germany, the United Kingdom, and Australia have shown an increase in alternative surgeries over the past decade. So, to conclude, I would like to talk about a system in place in our institution that has helped keep ESCH at an incidence of 0.03%. Now, we divide glaucoma patients that require surgery into 3 grades in ascending order of severity with an increased risk of complications. Now, grade 1 includes all glaucoma patients with open angles, no systemic comorbidities, and IOP in the target range or less than 20 millimeters of mercury. Grade 2 comprises of patients that need glaucoma and cataract surgeries, controlled systemic comorbidities, and IOP up to 25 millimeters of mercury and closed angles. Patients with an IOP between 25 and 30 millimeters of mercury and other glaucoma conditions that do not satisfy group 1 or 2 come under the 3rd category. Now, the idea behind the grouping is to help the surgeon decide on the surgical modality of choice with ease and with a clear understanding of the risk involved. So, the take-home message would be: expulsive suprachoroidal hemorrhage is a dreaded complication but avoidable. It can be prevented by taking appropriate risk stratification measures, opting for non-filtering surgeries for appropriate patients, immediate identification and quick intraoperative management, which includes stopping the surgery and closing the wound. Thank you.
Just one simple question, nice presentation. That did you modify the tunnel size also? Because as you said that all the cases underwent SICS with IOL and TRAP.
Yes, yes.
So did you modify the tunnel size also? severity of the glaucoma, or it was like simple, same length to everything, all the cases?
Ma'am,
That
yes.
explains a lot.
Among the cases that we had, we did the combined surgeries. We had one which was a mature cataract. So in that case, we had to have a large tunnel, whereas the rest were IMC. So based on that, not based on the grade of glaucoma, but rather based on the grade of cataract, we adjusted the size of the incision.
Difference noted in between, did you compare that?
No, ma'am, we did not take that into
This is a retrospective study.
Yes,
isn't
sir,
it? Yeah,
retrospective.
Right. So that.
So what
there are
happened was-
lot of things are, I mean, hard to find. But do you have in record
Yes,
that
sir.
all the trabeculectomies or combined procedure were done under mannitol or not? And
Yes, sir. So among the 6 that we
even
had,
after a IOP control, right?
yes, sir. So among the 6 that we did, 2 were given pre-operative mannitol during, in the block room before they were taken to the surgical theater, whereas the rest were not because of IOP, but because it was already controlled.
So even with the mannitol, they had the choroidal hemorrhage.
Yes, sir.
Those cases.
Yes, sir.
So thank you very much for this very
Thank you.
interesting study. I just want to ask you one last question.
Sorry.
That the incidence in the paper that you wrote up by Dr. Gede was very high, and you mentioned here also, and the incidence was very low in such a large series of cases.
Yes,
Do you have any explanation for that? Is just Caucasian and Indian eyes, or something else actually?
Sir, it is Caucasian, but whereas they also took a couple of things into consideration. Their sample size was less, much less than what we
But
had.
they have a higher.
They had a much
so
higher
that's not an
incidence.
important issue.
Yes, sir.
It's-
So what they took into account was both things. They took into account both intra-operative as well as.
I think one of the reasons that you included the non-penetrating surgery. All the previous studies have quoted intraocular surgeries. So yours is non-penetrating. You've included that
Yes,
thing
sir.
also. That's why I think you've tried to showcase this thing is nil. I mean, I don't know why you've added that. It's not required. It should be intraocular surgery. Then you should compare with the so-called expulsive hemorrhages, not by including that.
Thank you. Thank you very much. And yeah.
Dr. Bhavesh,
So-